how we can use that to help us. But I think the issues are the same. You know, they're sensitive but not specific. But again, if your clinical gestalt, much like PE and many other diagnoses, matters a lot in this case.
Right. I do know that I listened to a call with, I think, 4 emergency physicians and a few critical care physicians in New York City last week from Mount Sinai and a few other institutions. And they were at the point where they said they were treating patients based specifically on history, physical, and vital signs, and that they were overwhelmed and did not have the radiology resources to be able to be getting chest x-rays, CTs, and they weren't even using ultrasound really that much at the bedside either. But of course, their pretest probability and their prevalence of disease is a lot higher than what we're seeing here, so that obviously is impacting their diagnosis.
One of the things that has raised just earlier today, and I think it was going on Twitter a little bit, is about the possibility of pulmonary embolism as a secondary diagnosis in these patients, and that would definitely put pressure on us for our radiographic, your use of CT to make that diagnosis as well. So something to think about.
Yep.
Just a question with regard to that. This is Mike.
Go ahead, Mike, and then Joel.
I was just going to. Yeah, this is Mike. I was just going to say I've been reading about coronary thrombi and PEs as well.
Joel.
Yeah, so Ken, I had a question. Have you guys had any of the ward patients diagnosed with pulmonary embolism or DVT?
I'm going to look to my team here. They are saying no.
With COVID?
With COVID?
With COVID, no.
With COVID, yeah. Okay. We did have one in the ICU with their echo showed a McConnell sign, dilated RV, and we ended up treating them. Because of their instability from an ARDS standpoint, we didn't send them down for a scan. We just treated empirically. But it's something to be on the lookout for, I suppose.
Emily, we missed your question a little earlier.
Katie Dunn.
No, I asked the question. I think
Okay.
it was
Katie Demkoff. Sorry.
Yes. I was just wondering, Joel, you talked a little bit about the use of steroids, and we all know that they're being avoided as able. What are you running into in terms of patients with underlying COPD, and how are you making that decision in those patients specifically?
Yeah, that's a good question, Katie. So the other pulmonary docs around the state had asked too about steroids, and I think we're trying to not use them would be the kind of recommendations coming out of other places in the world, unless you have another indication. It's hard to diagnose sort of a COPD exacerbation in these patients in a PAPR because we can't really examine them. When they get intubated, we can tell from ventilator mechanics a bit if they have obstructive airways disease. And even there, we're kind of using bronchodilators alone and trying to minimize steroid exposure.
Ann Dean had a question.
I guess this is for Joel. If there is some thought that pulmonary embolism can be an adjunct diagnosis, is this considered a hypercoagulable state? And is there any investigation on that?
Not that I'm aware of. I mean, I think it's certainly a highly inflammatory state, and some of the we're not really seeing DIC in the patients. So I think you have to use your general index of suspicion for VTE, and we're having a low threshold to get echocardiograms on the hypotensive patients just to try to define, what their LV and RV function is, because there are these late reports of cardiomyopathy as well, though that's fairly undefined. So I think you just have to, use your clinical sense, and if you are concerned about it, either try to rule it out, or if the risk-benefit ratio is in favor of anticoagulation to consider anticoagulating the patient.
I think Don Med had a question.
Don Med?
Yeah.
Don Med, did you have a question?
Yes, can you guys hear me?
Yes.
Yeah, sorry, just a question came up from our assessment center yesterday about an admission. One of my docs thought a COVID positive patient was getting worse clinically and sent him to the emergency room basically for admission. But the patient wasn't admitted, so we're just kind of wondering what the threshold these days is in that scenario for hospitalization and what the hospital is relying on in terms of clinical symptoms and signs to determine hospitalization.
I can speak to that. At this point, we're really focusing on vital signs and work of breathing. And if this is the patient that I think I heard about yesterday from our COVID admitter, when they arrived to the emergency department, their vital signs were fine and their functional status was suitable, so they were sent home to be sick at home. There's a high likelihood for many of these patients who get sent home that they may represent. We're seeing a lot of presentations at 8, 9, 10 days of illness. So just because he was turned away once doesn't mean he won't be back. But at this point, we're trying as much as we can to avoid precautionary admissions that are otherwise stable.
Yeah,
Okay.
Mr. Stoll, just one last comment before I have to jump off.
Yeah.
We did see in the ICU a couple of patients with late staph pneumonia. So just if people are seeing sort of this late deterioration, to think about bacterial superinfection. And with that, I'm going to have to go.
Okay, thank you for your time, Joel.
I have a quick question.
Yeah.
For probably Don Med. This is Lisa Almeter. I'm curious as to when the patient is sent home, and to your point, Catherine, that they may deteriorate later. Is there a good and standard system by which they're getting frequently monitored so as to catch them when they potentially deteriorate, need to get back in? Are our PPP colleagues doing that, and how?
So, that's what makes us all nervous. We are having our care managers reach out to them we just got that system up and running so that, we know that there's additional eyes or, at least a phone call on patients who are COVID positive. But really, sounds like they need to be checked on daily. And it sounds like the O2 sat is really what is driving a lot of admission, that and just what they look like clinically in terms of respiratory rate and stuff for admission. Would all that be accurate, what I just said, or?
Yes, that is accurate.
Okay.
And just thinking along those lines, are we giving, when patients are sick enough to be home from the ED or from main med, do we give them an O2 sat monitor or make sure that they have something quick and objective to go home with?
Lisa, this is Christine. We don't currently have O2 sat monitors to send people home with, but obviously that's a pretty significant concern because these patients will have pretty severe hypoxia without associated dyspnea. And I do believe that there is some work going on right now about looking to shoring up home resources for patients, but it's in the early stages, and I think it is critically important.
That's great. Good to hear is that they can go home with a means by which to get very objective vital signs. That would probably take out a lot of the gray zone for Don and company.
Right.
Hey guys, this is Ross Isaac. I just wanted to take an opportunity because we have all these leaders here. I can tell you what we've done at Stevens Memorial, which is actually leverage Androscoggin. They have a telehealth system, much like Maine Healthcare at Home does here. They have O2 sat probes We're having nurses in the clinic and our care managers in the hospital call these patients daily when we send them home from either our testing center / respiratory clinic or the emergency department. We've been able to get some of them O2 sat probes, but we're encountering these same issues here. We recognize that this is a big group that can get very sick, and we want to address early, but try to keep out of the hospital if we can. So that's the limited work we've done thus far up there.
And anecdotally, I can say I've had 2 patients now who've had